Okay, good afternoon, everyone. Thank you for joining us for this exciting session, sponsored by Abbott, and which is entitled Mastering Mitral and Tricuspid TEER, Clinical Strategies in Patients with Complex Anatomy. So as you know, throughout the course, PCR has a main theme of complexity, treating even more complex patients in a simple fashion. So we're happy to have this session today with you. My name is Yohei Ono, interventional cardiologist from Tokyo, Japan, and I am delighted to be co-chaired by my friend KK from Singapore, interventional cardiologist. And we're fortunate to have a bunch of panel here, distinguished experts in this field. From my left side, Greg, he's the expert in imaging. Professor Suao from China, Dr. Mauricio Tarmasso from Zurich, Switzerland, and Atsushi from Nagoya, Japan. So, KK, do you want to give a word for the audience?
No, I think this is going to be an exciting session. We have crafted it with some case examples and from Asia, a little bit of sharing on the consensus document. And I think what's going to be important is the discussion afterwards.
Sure. So why don't you start your talk? So we recently had a quite intensive meeting, how to make this treatment more easy and straightforward. And so he has some talks regarding the consensus document of Asia Pacific Society of Cardiologists.
Thank you very much, Yohei, and it's a pleasure to see you here. So we are going to discuss the Asian Pacific Society of Cardiology consensus statements on the use of transcatheter edge-to-edge repair in the management of tricuspid and mitral regurgitation. So I put there the word draft because the paper is due to be published and we still have a bit of fine-tuning to do. These are my conflicts of interest. And I would like to add that this consensus effort is supported by unrestricted educational grant from Abbott Vascular. So this was the original consensus document from 2021, published in ECR. I'd like to say that the reason why the Asian Pacific Society of Cardiology decided to have a consensus document as opposed to a guideline is because it acknowledges the diversity of the region, the various socioeconomic development status of the different countries. But be that as it may, we required some form of guidance for the region. So this was in 2021. And 4 years has passed since then, and we now have met up a few times to come up with a new set of consensus documents accounting for tricuspid regurgitation as well. And I've already mentioned the reasons why we felt this was important for the region. There were considerations regarding not just socioeconomic resource funding, but also training as well as availability of the different technologies. For example, although the mitral clip is available in several countries, it is not available in most countries within the Asia Pac, and for other devices such as Pascal, even less so. There are also limited data from the region, and we do have medical legal considerations when an American or European guideline comes out. Well, how does it apply to the Asia Pacific? And while local guidelines do exist, we think we need something that is broader across the whole region. So how did we arrange this? Well, there were a group of experts within the region was convened, and we had one virtual and one hybrid meeting with a number of people who could make it in person, a meetup in Bangkok earlier this year. Now, the primary target for these consensus statements is the general cardiologist, but of course there is a bit of overlap with the individual subspecialty expert as well. So these are the panel members. Pardon me if the writing is too small, but I did not want to spend 4 slides on the number of members, but you can see there's a good spread of experts, and certainly there are more experts that could be there, but it would be impractical to have too many people on the panel. So we start off with the tricuspid valve TEER consensus statements. And I won't read through everything, but I think they are fairly straightforward. The first deals with the use of the 5-grade classification system that Rebecca Han and Zamorano had proposed, and I think this is now fairly standard. And you can see that the consensus was 100% in agreement. The second statement says that in the absence of other conditions requiring cardiac surgery, a TTR should be considered for symptomatic, severe, or worse TR if the following criteria are met. And I won't read out everything here, but again, there was a high level of consensus with 100% agreeing. I think these are based on clinical trial and fairly straightforward. The third statement refers to the effort with a multidisciplinary team. That is, an assessment by a multidisciplinary heart team is recommended in patients with clinically significant or severe or worse TR. And we listed out the people who should be involved. Again, the consensus was high, although the level of evidence is low. Now, we note that the ESC have put up guidelines recently, and this is an area where there is a slight divergence. In the ESC guidelines, I think right heart catheterization is largely recommended, but in our case, we felt that right heart cath should be considered in patients with severe or worse TR if the etiology is unclear or if findings are discordant. And the reasons for doing so are spelled out, that is to assess the contribution of left heart disease contributing to TR or pulmonary hypertension, and to determine the severity and type of pulmonary hypertension. Again, the level of evidence was felt to be low, but the consensus was high. The next two statements are on echo. The first is that transthoracic echo is recommended for the assessment of TR etiology and severity, high level of consensus. And if TEER is being considered, transesophageal echocardiography is recommended for the assessment of anatomical suitability. And again, the consensus agreement is high. These are what the group had felt to be anatomical considerations in terms of what was favorable, what was complex, and what was unfavorable. Again, I think this is grounded upon fairly well-accepted clinical evidence. We had also put in a statement to say that active infective endocarditis is a contraindication for TEER. I'll just pause a little bit to let people read. This is a flow diagram showing the evaluation pathway, and the thing is fairly straightforward. If a patient had symptomatic severe or worse TR as per our statement, then we should look at to see whether other cardiac surgical conditions are present that may mandate cardiac surgery. If so, then it goes to cardiac surgery. If not, then we look at suitability for TEER, and of course, if suitable, it goes for TEER. And if it is not suitable for TEER, then we look at other possible treatment possibilities, whether it's bicaval valve implantation or otherwise. And in countries that have TTVR, then it can be considered for enrollment in TTVR programs. And if none of those are possible, then either continued medical treatment for symptom relief or palliative care. We now move on in the last few minutes to an update on the management of mitral TEER. And the statements are very similar to what we had in the original consensus document. And I won't read out everything here, but essentially in symptomatic and asymptomatic patients with more than 3+ degenerative MR who meet the indications for surgery but are considered high risk by the heart team, they should be considered for MTEER. And for symptomatic high risk 3+ or more DMR with or without reduced EF, MTEER should be considered. This is again a high degree of consensus. I think the purpose of this statement is to force the clinical community to acknowledge that if it's a high-risk patient, one shouldn't just reject and say that it's not suitable for surgery and therefore don't offer anything, but indeed one should consider for MTEER. And MTEER may be considered for asymptomatic patients with high risk, that is more than 3+ DMR with reduced EF, less than 60%, and or LV dilatation, new onset AFib or pulmonary hypertension. And we just simply spelled out what I think is fairly accepted criteria. MTEER should be considered for 3+ or more symptomatic ventricular functional MR. And here the difference is that in the past we did not spell out ventricular. And the worry was that with now the recognition of atrial FMR, that we should be clearer about what we mean when we say functional MR. Who are already on optimized GDMT, including CRT, were indicated. Again, a high level of consensus and a good level of evidence with the recent ReShape study. For patients with ischemic FMR of more than 3+ or more, coronary anatomy and ischemia evaluation should be performed before MTEER. And if PCI is performed, a stage M-TEER therapy should be considered for severe symptomatic FMR. Again, it gives a bit of cover for physicians who stage their procedures in patients with severe ischemic FMR. And for patients with ventricular FMR, they should be monitored regularly. And we give a bit of a time frame again to provide guidance for this part of the world. Sorry, I meant the Asia Pacific. And referred early to the heart team if they were for potential M-TEER treatment. Again, a very similar statement here regarding the assessment by the heart team. For ventricular FMR patients who do not meet eligibility criteria for M-TEER, such as those who are asymptomatic, etc., they should be closely monitored, and where appropriate, they should be considered for M-TEER. Patients with symptomatic atrial FMR, this is a new statement, should be evaluated by the heart team, including an electrophysiologist and heart failure specialist. And if treatment has really been optimized, we felt that M-TEER may be considered. Patients with less common scenarios of MR should be evaluated by the heart team on a per-patient basis to determine whether M-TEER use will be feasible or beneficial to them, and we recommended enrollment into clinical trials or registries. This is a very similar diagram. We added a few specific criteria as to what were considered complex and what were considered inappropriate. I think we now note that complex, we allowed for valve area of between 3 to 4, largely on the back of data from Japan. This flowchart is unchanged from before in terms of the assessment of ventricular FMR. So in conclusion, the APSC consensus guidelines recommendations represent clinical guidance for general cardiologists and takes into consideration evidence at a global level and also regional data, perspectives, practice patterns, and limitations. Thank you.
Thank you, KK, for your comprehensive review of this great statement. Why don't you come back here? Let's discuss a little bit about tricuspid TEER, since we will deal with two great cases of mitral TEER later on. I would like to ask you, Greg, since you have a huge experience in this field, KK mentioned about the 5-grade severity assessment scale for the TEER assessment. So in your daily clinical practice, I know you have a busy program. Do you always grade TEER severity in this 5-grade, or in only patients who is considering to be a candidate for tricuspid TEER?
So there's a few elements to that question. Key things are: 1, transthoracic echo first for screening and entry level, and also for volumetric assessment, I think. Secondly, I think everybody should be thinking in the 5-grade scale, but much more important than that, quantify. Mm-hmm. So 3D VCA or EROA, remembering that the tricuspid valve has a lot less ballistic power behind it. So right ventricle is ballistically a lot weaker than the left ventricle. So an ERO will have a different amount of volume behind it and a different amount of plume of jet. So you can't trust the plume so much. So I think that quantification's key. The other thing is that when you do these procedures, you get from torrential to moderate, and that's a massive win. You get from torrential to even severe, it's a massive win. So that if you're not doing that, you're underselling the technology, and I think also if you're not doing it, there's a chance you'll inappropriately get people who are too low down the scale as well. So quantify.
Mm-hmm. Thank you.
And you know, Yohei and Greg, I wanted to say that the comment that I made about how this statement is targeted at a general cardiologist, I think acknowledges the fact that across the Asia Pacific, you know, I think we account for a huge proportion of the Earth's population, but the number of cardiologists are actually relatively few compared to the West. So we were quite clear to make sure that these recommendations would be applicable to the majority of practitioners of the art within the Asia Pac.
It's very much a clinical statement. This is a clinical statement of how you medically manage the people, and then the subtext of the accuracy of the echo and the assessment is for deployment then.
Exactly. So similar question to you, Professor Chuang. So how do you apply this quantitative or semi-quantitative assessment of TEER severity grade?
Yes, we did not have so many cases on the TTR, but when we do the MTR, actually we follow the similar pathways. We have the semi-quantitative or quantitative. Like for some case, we essentially use the PISA to evaluate the EROA. So in my center, when we do the TTR, so we also follow this. Especially in China, we did not have so many time to evaluate before the procedure. So we'll ask our echo doctor to do the image to give enough index for us to evaluate whether it's qualified to do the TTR. Yeah, so I think it's very important to before, and then we discussed all this index before on the heart team. Yes, this
Thank
is
you.
critical.
Great comment. So let's talk a little bit about atrial functional MR, which Keiki also highlighted as a new statement for this consensus document, which was also highlighted in this year's ESC new guideline. So Maurizio, tell us a little bit about your experience treating mitral TEER for this atrial functional MR patients.
Yes, as you said, for the first time, this concept has been introduced in the new ESC ACTS guideline. And let's say quite differently from before, there is a recommendation also to consider surgery that may be considered in those patients. So if it is purely atrially driven FMR, usually it is secondary to annular dilation in the context of atrial fibrillation. And then this is something that may be eventually surgically treated with the surgical ablation and then annuloplasty. Usually those patients, they do have preserved ejection fraction and they do not have such a high risk like patients with ventricular FMR. On the other hand, we have data from the expanded registry and then from also our basically daily clinical practice that we can achieve good result in atrial FMR. Yep. Therefore, especially if the chance of restoring sinus rhythm with ablation is little, I think it's still a really good indication. There is no tethering, so the risk of tension in the leaflet and eventually having a tearing of the leaflet is really low, and usually the gap is not that big. So we do quite regularly atrially FMR, and the outcome are, I would say, at least comparable to the one in ventricular FMR.
Yeah. So as you mentioned, AFib plays a big role. However, the patients also often have huge dilated atrium, so it will be difficult to restore sinus rhythm. So Atsushi, finally, you have huge experience both in the mitral and tricuspid space. So often, patients with AFib has both mitral and tricuspid regurgitation. So how do you approach these concomitant, staged? What is your strategy?
Oh, it's such a great question. So, it's a patient with mitral and tricuspid is sometimes not easy to treat all of them. And basically, you go first a mitral, and you see what happens to the tricuspid after the procedure. But we need to know that 30 to 40% of patients will have improvement of tricuspid ligament. On the other hand, 10 to 15% of patients will have worsening of tricuspid. So we need to care, sometimes really cautious about how tricuspid develops after the procedure. In those cases, probably we need to go faster to tackle tricuspid regurgitation even after mitral TEER.
Thanks very much, Sushi. So I think we have heard a bit about the Asia-Pacific consensus recommendations and the discussion around it. And earlier on, we had also, and as Asushi said, and the role of AFib in atrial FMR. And maybe with that background, it's good to invite Dr. Shunsuke Kubo to give us a talk on concomitant implantation strategies for MitraClip and amulet. Kubo, please.
Thank you, Kike, and thank you for the opportunity to present my case today. So my topic is a concomitant procedure of the TEER and airway closure procedure. So where the concomitant procedure is needed? So because our patient is a very high bleeding and stroke risk patients. So from our ocean mitral registry in Japanese, a large registry, actually the prevalence of AFib is around 64% of the patients requiring TEER. And also that these patients had a high age and the history of a lot of patients have a history of the PCI or stroke. And also most of the patients have a chronic kidney disease. And also baseline hemoglobin level is low. So additionally, we have to care about the risk of the peri-procedural stroke after the TEER. So this patient is an 85-year-old gentleman who had a severe atrial function MR. So you can see massive MR, but the baseline TE shows that there is no smoke sign in the appendage, but after 2 device implantations. So you can see the mild MR, so MR reduces, but you can see new smoke sign in the appendage. So unfortunately, 2 days later, the acute stroke occurred in this patient despite OAC continuation. So we send this patient to the neurosurgeon for the thrombectomy. So some studies show the safety of the concomitant procedure. So most of the studies show of course, increased procedure time compared to the mitral clip alone, but actually the complication rate is quite similar between the concomitant procedure and the mitral clip alone. And also, most of the patient can stop the DOAC after the procedure. So most of the patient takes DAPT or SAPT after the procedure. But one of the challenges of the concomitant procedure is a position of the transcatheter puncture. As you know, usually the TEER procedure requires the mid, superior, and the posterior puncture of the fossa ovalis. But a LAAC closure, we need the inferior and mid or posterior puncture of the fossa ovalis. So which position prefer to the concomitant procedure? So I personally prefer to puncture the inferior and the posterior. Because in this case, we puncture the superior and the posterior in the fossa ovalis. So the mitral clip is a very straightforward case. We put the 1XT in the H2P2, but when we move to the LAAC closure procedure, as you can see, the cyst is coming from the very anterior. So the coaxiality is not so good. So finally, we failed to implant this watchman device in the appropriate position. So I think that there is a priority to coaxial alignment to the appendage over the height to the mitral annulus in this concomitant procedure. So this is a case, an 80-year-old gentleman who had a multiple history of the CABG and also the mitral valve repair using the semi-rigid Physio 2 30mm ring. Unfortunately, 3 years later, the MR recurred, and he was referred to our hospital due to the worsened dyspnea. Also, he had also history of the AFib and intracranial hemorrhage under the DOAC. So he was a little bit frail, and he had also the high CHAS score and heart score. So optimal the medication was the medical therapy was almost optimal. So renal function is normal, but the BNP level is a little bit high. So this is a TTE. You can see the direct left ventricle, but the LVEF was 51%. So you can see the surgical ring and the severe MR with around the 10 millimeters of vena contract width. So due to the first mitral valve annuloplasty, so MVA was only the 2.88 square centimeter, but the mean pressure gradient is 3.1 millimeter mercury. So this is a TEE. You can see the ring here, and MR jet are coming from the four parts of H2P2, but as you can see, the medial jet is a little bit larger than the lateral jet. So this is a biplane image. You can see the left panel shows A1P1, and the middle panel shows A2P2, and the right panel shows A3P3. As you can see, the main jet are coming from the A3P3. I think due to the posterior leaflet tethering due to the ring annuloplasty. So this is the non-color explained image of the A3P3. So there is a tough visualization in the posterior leaflet, but in the LVOT image, you can see a little bit posterior leaflet here. But the length is so limited, is about 6 millimeter. So this is the TEER assessment of the appendage, left atrial appendage. The upper panel shows the 45 to 135 degree, and the lower panel shows the 0 and 90 degrees. As you can see, that there's a lot of the pectinate muscle in here, but the length here is around 40 millimeter. So I think that this is not suitable for the appendage closure is a landing zone here. But we set the landing zone here, this pectinate muscle and this appendage wall. So when we set the landing zone here, actually the maximum landing zone diameter is 28 millimeter, and but the minimum landing zone diameter is only 19 millimeter. So this is oval shape appendage. So this is our strategy. So transpuncture site is the inferior and posterior of the fossa ovalis. So of course we use the NT clip because of the small mitral valve area. So personally, I prefer to select a little bit undersized amulet device recently. So we select the 28 millimeter amulet device due to this oval shape appendage. So this is actually the procedure. Transcatheter puncture was performed of inferior posterior, but there is only the 28 millimeter height above the mitral surgical ring to the tenting. But I think this patient has a tethered posterior leaflet. I think that there is around 30 millimeter from the tenting to the tip of the leaflet. So this is the picture of the leaflet grasping. As you can see, the anterior leaflet grasping is very nice. But we cannot see the posterior leaflet very well, so I confirm the posterior leaflet insertion in the deep esophageal image. So in this image, there is no leaflet between the arm and the posterior wall, so it means the posterior leaflet just above this arm. So we put the gripper down in the anterior first, anterior gripper down first, and the different insertion seems to be great. But the posterior gripper cannot be visualized in the TE, is also a transgastric image. So I confirmed the gripper attached to the leaflet using the fluoroscopy. As you can see, this is a gripper. The tip of gripper just attached to the leaflet. It means the gripper grasps the posterior leaflet and the link together. So after closing the device, the MR is significantly reduced to mild. So we release the clip, the mild MR after the release, and you can see the stable device like that. So mean pressure gradient is only the 4 millimeter mercury. So next we move to the procedure of the appendage closure. So actually the guide sheath was changed to the 20 French long sheath, and amulet delivery sheath was inserted via this long sheath. So this is appendage angiography. So there's so much pectinate muscle here and here. But as you can see, the sheath was really coaxial to the landing zone of the appendage. So we deploy the lobe like this. So the lobe position is very nice. And also after that, so we deploy the disc. So during the deploy the disc, the distal lobe was quite stable. Its anchor is good. So we release the device. So this is a 3D MPR image after release. The lobe is very optimal, and there is no significant leak around the device, and also there is no peri-device current flow into the appendage. So this is the final result. The mild MR, the pressure mean gradient is only 3 millimeter mercury, and the procedure time is less than 90 minutes. So we complete the 3 months follow-up this patient. So patient still NYHA class 1 symptoms. So TT shows the mild MR, the mean pressure gradients are less than 5 millimeter mercury. In TE, there is no DLT and peri-device leak. So we prescribe the DAPT after the procedure and then change it to the aspirin monotherapy. In summary, the concomitant procedure is a safe and effective strategy for patients with severe MR at high bleeding risk. I think a transcatheter puncture should be performed with priority to achieve the coaxial alignment with the appendage rather than maximizing the puncture site. Thank you for your attention.
Wow, Shunsuke, it's a really nice case. And I had exactly a patient like that who, in your first case, that was a VIP and who had a stroke after I did the mitral, and it was very sad. But, that's why we have these, discussions. So as you present this case, I guess the first question that came to mind is, what kind of patients, would you immediately consider for a joint procedure with edge-to-edge repair and left atrial appendage occlusion? Is it only the high bleeding risk, but are there any other subsets of patients that you would consider?
Thank you, KK, for the great question. So ideally, I think that I can perform the concomitant procedure in the old patient with the AFib and MR. But personally, I only do the high bleeding risk patient and also the high stroke patients, because same to you, I experienced 3 cases with acute stroke just after the procedures.
Thank you.
Yeah, the spontaneous echo contrast, as you emphasized, smoke sign, on the one hand, it's a good sign that you have significantly reduced MR, but on the other hand, it may cause a risk for stroke, so it could be difficult. So Greg, what have you... Oh, please. You're always welcome for any kind of questions, comments.
Just to say that actually, when you have a severe mitral regurgitation and you have a LA enlargement, the issue with the posterior, inferior for the LAA and for the clip is less relevant because you have huge of space and you can puncture actually quite next to the PFO. Even you can go through the PFO with an enlarger LA and close the LA without problems. Yeah.
Any comments on that?
Yeah, I think that in the European countries, your patient is a very huge left atrium. You know that. But our Asian countries is very small heart, and the left atrium is space limited. It's sometimes difficult to negotiate the good trajectory for the appendage. But recently we have steerable cat seats for the appendage. When we use the steerable seats, the puncture site is sometimes the superior puncture is good.
Thank you. So, Greg, would you consider this kind of concomitant procedure in some specific patients? And if so, what kind of patients?
I think what worried me about the first case is that the stroke happened on DOAC, because we see smoke all the time. We take it as generally a positive thing, and we generally take comfort in the fact they're mostly on blood thinners, and we think it's going to be okay. So your case showed us that, and probably with some stenosis maybe, that even on blood thinners the person had a stroke. That is terribly worrying. Second thing I wanted to say about your case, which was beautiful, was that the posterior leaflet was in the shadows. It was in the shadows of the ring, and you did some things, alternate views, push the probe in, low esophagus, pull the big wheel towards, look up underneath the shadows. I think you did a good job of that. I think you said that you saw the leaflet on the fluoro, which I thought is that the gap between the gripper and the arm. That was very impressive. And sometimes a transgastric, pull the wheel hard, you can see the posterior leaflet out from underneath the shadows. I thought that was beautiful. And in answer to your question about stroke, I think gradient is the thing that worries me. If you see gradient, and that makes me worry much more about stroke.
I have a question in terms of the various countries we come from. Would there be reimbursement for a joint procedure like this? You think it's possible? In Japan, what is it like?
In Japan, actually the procedure fee cannot be obtained, both procedure fee. So only one procedure fee, the appendage closure or mitral clip. But all device fee can be reimbursed.
Okay, in Zurich?
In Europe, it depends on the country. In most of the country, there is no reimbursement for combined procedure. In Switzerland, it depends on the insurance status of the patient. So if the patient is well insured, the insurance will cover. If not, it may not cover.
Right.
So this is obviously something that you consider if there is no a strong clinical indication to do concomitantly, to do eventually staged.
What about China?
Yes, I have done similar case 2 years ago, but much more simple one. In China, actually we can do both several different procedure, especially when he used the one pathway. And that's good for the patient. But I do agree with you that you when you do the puncture, you prior to the LA occlusion. But there are different two scenarios. First is beneficial. When you puncture anterior or low, it's good in your case, both for TEER or LA occlusion, because you're doing the clip in ring. So you need to use very hard L-hug angle and posteriorly let so limited, so it's good. But in another scenario, when you do the atrial FMR patients, you need to anti-hug. So this puncture height usually is not enough. So I don't know whether you have any experience about this kinds of patient.
Can I answer? Okay.
Yeah.
I think that the inferior, the posterior is good. Inferior, the anterior is not so good because the anterior puncture is going to be the outer hugger. But the inferior and the posterior is usually going to be the anti-outer hugger trajectory. So I think it's inferior posterior puncture can be standard, can be covers most of the anatomy.
I don't think we should be afraid to do two punctures if you have to.
Okay.
Where we've been caught with this, where we have a beautiful mitral puncture, do a beautiful case. Axiality is terrible for the LAAO.
Yep.
We persevere and persevere. And in fact, what we should do is pull out and just do a proper puncture for the LAAO.
Yeah, that makes eventually the procedure time shorter.
Yeah.
Would be right. All right, thank you for your great case. And for the sake of time, we would like to move on. I'd like to introduce Professor Zhuang for giving his interesting case, challenging TEER imaging, mitral clip in a heart failure with patients with severe cardiac malposition.
Okay, thank you for the introduction. And we all know that the guideline, the ESCC guideline and the AP guideline has changed, upgrade VFMR as the level 1. So the guideline is good, but sometimes when we do TEER, it's not, especially with the FMR patient, very severe cardio malposition. So I will share a case that very image challenging in TEER. And this patient looks quite special, especially when he is so obesity and he's not that height. And he has a history of proximal effort and had a mild previewed MI with a PCI history. And echo finds that the LV have the apex aneurysm and very severe to functional MR, and also combined with the moderate TR and pulmonary hypertension, moderate. And LVF is around 20%, and also his right heart is also impaired dysfunction, and very high anti-proBNP, and STS score is around 3%. So this is quite challenging when we the heart team discussions, because this patient raised several challenges. First is the anatomy, because it's so obesity and it's not that high. It's very shocked female, and also the severe cardio malpositions and the LV apex aneurysm. So when we do TTE, we can see the image is not that good. And also this kinds of patient usually have a poor prognosis, very severe LV and RV dysfunction and pulmonary hypertension, especially when it's more than 17 millimeter of mercury, and also the moderate TR. So we can expect some procedure challenge. It is difficult to obtain the standard echo field because of the location or the alignment. So just like us expect, before the procedure we do TEE, we fail to gain the back compute. No matter how many tools we use, we can hold down change the position, the patient's position, or use the TTE to help. So we cannot get the bicom views. So we can see it's the suboptimal well exposed due to the cardiac malposition. And we change a different strategy. We can see the anterior and posterior coapt, but we did not get the very beautiful bicom view. And then we can see that why we need the bicom view, we just only need to identify or locate which part or which zoom of the valve. When we graph, we only look at the LVOT view. So we can see that when we look at the LVOT view, we can see the MR caused by the lead left strain. So if I on the light, I can identify the origin of the MR, and we can see clearly the lead left. So I can do the grasping. So it's enough. After that, we have come from several cases. So we use the different strategy. So we can just push the probe and anti-flex to get the short X. So we can identify the origin of the MR, and also we can look clearly at the posterior and anterior lead left very clearly here. And so this case, we do use this short axis view to do. And from the fluoroscopics, we can see it's quite difficult. At first, I already damaged the SGC because very great tension. So the SGC already like damaged by this twist vessels. So after we insert SGC, it's placed in a very weird position. So this is very malpositioned. And also the echo guide SGC insert, we can see it not that clearly because the echo image quality is impaired by the body. From the 3D fast view, we can also maybe we can see the orientation. So we recheck the SGC under the fluoroscopic guide, and we do the straddle. We first actually we put the SGC very high, very deep, and then we push the clip, and then we push back the SGC and do the straddle. And then after the steering, we change the clip to lose the parallax. So this is very important because in the normal case we would do this kind of the movement, not that critical, but for this patient, it's very important to create a fluoroscopic backup view. We can use as an anchor, and then use the 3D inverse view. We can see the orientation can be confirmed, and from the in the middle of the origin of MR. So when the clip orientation is correct, we can do the alignment, realign using the fluoroscopic. And from the LA to the LV, and during the grasping, we keep making it alive. And then under the short axis views, and we do the expand, we can see very clearly the grasping. So we use G4, and we grabbed using the identified grasping. We grabbed the anterior left, and then move to the posterior and clip close. Very clear grasping duration. And we can see it so clearly. The tissue bridge is looks stable, and then we also confirmed by the fluoroscopic guide clip, and we can see after the grasping and the deployment of the clip, the orientation is very is correct, and also the tissue branch looks good, and only trace resistant MR. And also we can also to scan for the M side or the L side of the clip. We did not see much residual MR. So after the final dismiss, we can recheck the whole system. So in this case, I think the fluoroscopy is critical because we did not get so that much clear echo view. And the final result, it looks good. And also the pulmonary speckles improve. And the follow-up 1 month and 1 year, the patient keep following up, and very good duration of the MR, and we can see the improvement of the anti-proBNP and the ejection fraction also improve. So for this case, and I think most of the FMR patient, he will raise some challenge, especially when we did not get enough or clear echo image. So with anatomy change, most of the patient will have this kind of the problem. So we do not try to pursue the very standard echo view. Sometimes the non-standard view is enough or can be used for the left grasping. And also fluoroscopy is not a substitute for echo, because in China, some center they would do pure echo. But I think the DSA is very important, especially when echo cannot define the collector. So maybe the 3D infarct view and the fluoroscopics by compound can combine together, so to do a very clear alignment. So this synergy enables successful TEER in this complex patient. Thank you.
Thank you so much for sharing this difficult and challenging case, and really congratulations. So before asking our imaging master, Greg, I would like to ask Atsushi. I know you have a lot of tips and tricks when you face this kind of suboptimal imaging, how to overcome. So any suggestions?
I would, from my perspective, if we know prior to the procedure, if we know the difficulty of imaging, so I would go CT, cardiac CT, to know how large your left atrium is and how the mitral valve anatomy is. That would be really helpful. And the another option is definitely 4D eyes if you have. So that would have been also helpful, especially for confirming leaflet grasping during the procedure.
Yeah, thank you. I think CT scan is very important, but I do thinking about a question that if you do CT scan, so how can I let the CT image imply which position, or how to optimize the echo degree, or to make it clear during the TEER procedure?
I mean, at least you can know how large the left atrium is, and so that, for example, steering down the catheters, if you know the left atrium is large enough, you have no concern about steering it down. And then also and also using the 3D Menzio application, you can also simulate. We can do a simulation of transesophageal echo using this CT image. That will also be helpful.
Thanks.
All right. Any suggestion from Greg? And do you consider using, as Atsushi mentioned, like 3D, 4D ICE in mitral space? We know that it's useful for tricuspid, obviously.
So the teaching features of this wonderful case, and in fact we've had a few like this, don't forget transgastric. Remember when we started 10 years ago, transgastric was every case, and the axiality of the perpendicularity of the clip to the orifice where you think the leak is, a lot of that used to be done in transgastric before we were doing all on-face 3D. So that's really nice. And X-planing, if you're lucky, and you were lucky, that your X-plane went exactly through the clip arm, so it was perfect. I think get your axiality, however you do it, set the C-arm for parallax, and then use it to keep axiality. You did that, and then you had beautiful grasping views. And again, pull the big wheel. The problem here is that the esophagus and the dome of the left atrium weren't next to each other. So if you looked at the TE probe, it was way over in the left chest, pointing backwards across the face of the mitral valve. Sometimes you can turn the little wheel to the right. Some esophaguses you can move with the little wheel to the right to bring the probe and the esophagus back over the dome. But I'm sure you tried that very hard, and you don't want to hurt the person. But that's sometimes a trick you can use.
Yes.
You know, one of the questions I had as I saw the case is when you did the pre-procedural planning, did you all anticipate that you would have this problem? You know, the pre-procedure TE would give you a sense that this might be a problem.
Actually, we don't think about this because most of the patients, they look like this, very severe function. But obesity patient, we don't think it's like it's a challenge for the image views. So I think the question is that how would I know the next case would be the very poor image patient? Because some of the patient he cannot tolerate to do the TTE.
Right.
Yeah.
Yeah, maybe another way to utilize the CT scan, as Atsushi mentioned, is that to understand how the esophagus goes, because it may be impacted by the vertebra. So you can by using that CT scan information, you can tell which view could be, provide an optimal image, like maybe in some cases deep esophageal view or mid esophageal view. That would be another thing, I guess.
Yeah, exactly. That's really what I meant, and then that would be really important information, especially because in patients with functional mitral regurgitation, normally we see the leaflet are healthy, so we sometimes go procedure without prior TOE. In such case, you looking at cardiac CT would be really helpful to understand how the esophageal goes.
Thanks.
Thank you again.
Just a lot of time, like you say, you make the pre-interventional, you make it in a side position, and you have great images, and then suddenly you are in the OR, and you don't have the view that you have before. So you can, of course, change the position of the patient, but sometimes it's really difficult. And the same is about the CT. We see it in the TAVI. You plan everything, and then it's enough that there's a little change in the OR, and you lose everything. And you see, even when you make the intervention, that the echocardiographists just move a little, and suddenly you have a great vision, and the 2 minutes later is not there. So it's really, like you said, it could be very difficult, and you cannot foresee everything.
Exactly.
You don't need 4D ice. So 2D ice, once you've got axiality, and you set that by the fluoro and by your CT or transgastric, but if you still can't see leaflets, single plane ice, and move the ice to the clip, not the clip to the ice, just to see the grasping. And that's pretty cheap, actually, single plane ice compared to 4D.
Yes, I have another question. So would you use the NPR?
If you can. So if that picture that you had from the side, the esophagus is here, you're looking back across the valve, sort of from here, then sometimes you can still NPR on that. It wasn't bad, and you might have been able to get, at least for the axiality, because once you've got axiality and you set the C-arm, you're okay. And then you get into the ventricle and then find some angle where you can see leaflets, either by what you did, beautiful, or if you can't, then single plane ice would do it.
Yeah, thanks a lot.
Okay, Kay, do you want to pick up a question?
Yeah.
We have a...
Thanks, Dr. Chuang. Dr. Chuang, why don't you come back to this seat here? We have a question from the audience, and I think it's one of those eternal questions. Any suggestions on concomitant M-TEER, M and T-TEER? So maybe I'll ask Maurizio, when do we think about concomitant M and T-TEER? Maybe we'll let Maurizio answer, then I think there's a comment from the ground, yeah.
Mm-hmm. Yeah, I try to make a rapid answer. I think at least we do really rarely in selected cases concomitantly mitral and tricuspid, but I think it's highly depending also on some factor like geography and reimbursement as well. As you said before, in some country concomitant procedure may be reimbursed, in some other no, and this obviously is a weight in the decision. And then also the distance between the tertiary center and the referring center. So if the patient is coming, especially if he's old, is coming from really far away, and then he might not come back to do the tricuspid. So if you already know that this patient has severe TR concomitant to severe MR and is not going to come back for the follow-up, you may consider to treat it. But these are obviously not clinical element. I think the only real case where we would definitely treat also TEER concomitantly is when after the treatment of the MR, there is bidirectional shunt with the saturation. So you have big right to left shunt due to the severe TEER. You may obviously consider to close the ASD, but obviously you can also consider to treat the TEER immediately. This is probably the only situation where we would go for concomitant. Otherwise, we would wait 1 to 3 months and then treat in a staged way.
Yeah. There's a comment from the ground.
It is a comment, yes, not a question. So in your case, when you have obliquely aligned heart, you need only one clear view and you will take it from there. In your case, you have a very clear short axis transgastric, okay? So in this case, I would do a biplane image. So in the other side of the image, you have the long axis, and in the original image, you have the short axis. So I will go from left to right, or from right to left, A1, P1, A2, P2 in the middle, A3, P3 on your left side. And from that image, you can put color, you can know where the origin of the MR jet exactly coming from where. You can do your clocking in this view. You can do your grasping in the other view. So I think this transgastric view, it is very clear. And even after the deployment of the clip, we see very clear figure 8 very nicely. And with color also, we can see is there any residual. So I think transgastric view, the clear one, solved all our problems, I think, in this case. Thank you.
Thank you very much. You know, I wish we had more time to discuss further, and I actually have additional comments about some of the cases here. Before I close, any comments from the panelists before Greg,
you wanted to say something?
Kubo, anything?
I was just going to say that don't forget the small wheel in the stomach. You can move the stomach around a lot. Remember, the right transgastric short axis tricuspid view is way over here. And so your point is right, but there was a bit of luck because where he wanted to put the clip was perpendicular, beautiful to the X-plane. But if it was, say, it was out here somewhere, maybe in the ones, he might have been able to turn the little wheel left. And that would have brought his angle around so that the X would have been axial here, or turn it to the right if he had to be out here. So there was a bit of luck, but don't forget the small wheel.
Okay, I think we are good with the program. Let me just summarize today's session. I think you have heard about the Asian Pacific Society of Cardiology's consensus documents, very similar to what Europe and the US have put forth, except that it's contextualized to the Asia Pacific. And I think in today's session, we heard about complex anatomy and some of the nuances. I think first, the complexity of a transeptal puncture and how it might be optimized in the setting of a combined TEER and left atrial appendage closure procedure. And then we heard a very robust discussion with contributions from all of you in the audience about how one might optimize imaging for a difficult anatomical scenario with a malpositioned heart. And I think the learnings on using the various TOE or TEE probe imaging tools, as well as the transgastric, something that we now perhaps may have forgotten, but we should not forget as evidence, has been very useful in helping us approach complex M-TEER and T-TEER procedures. So with that, I'd like to thank all of you for participating, my co-moderator Yohei, and our panelists and speakers, and of course, Abbott for sponsoring today's educational symposium. Thank you very much and have a good evening.